So, in this video, I am going to discuss about highly active antiretroviral therapy, AIDS defining illness, what are the various infections which occurs in different CD4 count levels, what are the side effects of antiretroviral drugs. So coming to AIDS defining illness, it is esophageal candidiasis which is considered as an AIDS defining illness. Remember, oral candidiasis caused by Candida albicans species is common in HIV patients, but it is not an AIDS defining illness. So it is esophageal candidiasis. Pneumocystis jirovecii pneumonia, then HIV encephalopathy, okay? Then disseminated mycobacterial infection. Why I stress that word? Because what is the most common opportunistic infection in HIV patients? It is tuberculosis. But TB is not an AIDS defining illness. Disseminated mycobacterium tuberculosis is an AIDS defining illness. What do you mean by defining illness? If a patient have esophageal candidiasis, I can say that the patient is having AIDS. That is the meaning. So it is disseminated mycobacterium, especially caused by Mycobacterium avium intracellulare complexes. Okay, then cytomegalovirus retinitis. Then coming to the malignancy, the classical AIDS defining malignancies are invasive carcinoma of the cervix, primary CNS lymphoma. Okay, that is actually the most common malignancy in HIV. It is primary CNS lymphoma. Then Kaposi sarcoma, which is the most common skin malignancy in HIV. Okay, so these are the AIDS defining malignancies. Then coming into the organ systems which are affected by AIDS. First, let us see the cardiovascular system. In cardiovascular system, they causes atherosclerotic coronary artery disease. That is the most common cause of death in AIDS patients. You know that in HIV patients, the virus itself does not cause the mortality, but the mortality is merely because of the opportunistic infection. Out of that, the most common cause is coronary artery disease. Coming to CNS, in CNS, I have told you there is cytomegalovirus retinitis, HIV encephalopathy is common, AIDS dementia complex is seen, okay, and there is primary CNS lymphoma. And what is most common cause of meningitis in HIV patients? It is cryptococcal meningitis, okay. And as far as another space occupying lesion of the brain is concerned, it is cerebral toxoplasmosis caused by toxoplasmosis gondii infection. Fine. And there is a CNS response to HIV, that is what we call it as microglial nodules, okay, which is seen in biopsy of the brain. And coming to GIT, we will get colitis, there will be diarrhea, and there will be candidiasis, okay, that is esophageal candidiasis caused by Candida albicans. Even herpes zoster do causes esophagitis in HIV patients, and the most common cause of diarrhea in HIV patient, it is always Cryptosporidium parvo. Then coming to renal manifestation, the most common is nephrotic syndrome. Nephritic syndrome is rare, and the most common cause of nephrotic syndrome in AIDS is focal segmental glomerular sclerosis. We have a variant called as a collapsing variant, okay. Collapsing variant of FSGS is the most common histological pattern we see in case of HIV patients. And respiratory pneumonia caused by pneumocystis jirovecii pneumonia. And remember, here there will be bilateral patchy interstitial infiltrates. But if the question mentioned that okay, it is consolidation pneumonia, again consolidation pneumonia in HIV is caused by streptococcus pneumonia only. But if they ask you what is the most common causative organism for pneumonia in HIV, it is pneumocystis. Then coming to skin, I have already told you it is Kaposi sarcoma, and another one is bacillary angiomatosis, which is caused by Bartonella Hensley. Coming to cause of death, I have told you because of this opportunistic infection, and the major cause of death in AIDS patient is again coronary artery disease. Coming to the various CD4 counts and the infections occurred, TB occurs when the CD4 count is more than 300, and between 200 to 500, what are the infections? It is oral candidiasis and herpes zoster. Less than 200, we have the pneumocystis jirovecii pneumonia, and AIDS dementia complex occurs below 200 only. That is why below 200 CD4 count, we have to start cotrimoxazole prophylaxis. What is cotrimoxazole? It is a combination of trimethoprim and sulfamethoxazole. Both are sulfonamide group of antibiotics. We have to start, that is a single drug we are available as a fixed drug combination, that is cotrimoxazole, and that prophylaxis has to be started immediately. And below 200, we have the toxoplasmosis and cryptosporidiosis and cryptococcosis, and below 50, CMV retinitis and Mycobacterium avium complexes. So coming to the treatment, irrespective of the CD4 count, irrespective of the stage, start the treatment even in pregnancy also, lifelong treatment. This is the dictum in HIV therapy as per NACO guidelines. And remember, we have different classes of antiretroviral drugs. One is nucleoside reverse transcriptase inhibitor. Second is non-nucleoside reverse transcriptase inhibitor. Third is nucleotide reverse transcriptase inhibitors. Fourth is protease inhibitors. Fifth is fusion inhibitors. Sixth is integrase inhibitors. So earlier we followed a regimen called tenofovir, lamivudine and efavirenz. tenofovir is a NRTA, nucleotide RTA, reverse transcriptase inhibitor, and lemivudine is a nucleoside reverse transcriptase inhibitor, and efavirenz is a non-nucleoside reverse transcriptase inhibitors. Now, the narcogalins have changed the regimen. It is TLD. Whether it is a post-exposure prophylaxis following a needle stick injury or for a treatment regimen, pregnant women, whatever it may be, unless and until there is no other contraindications for the drugs, we have to start tenofovir, lemivudine, and dolutegravir. Dolutegravir is an integrase inhibitor. Okay. And as far as the post-exposure prophylaxis in needle stick injury is concerned, immediately within 2 hours and maximum within a period of 72 hours, the post-exposure prophylaxis has to be started and has to be continued for a minimum period of 28 days. So coming to the common side effects of HIV medications, protease inhibitors. Protease inhibitors are the ritonavir, lopinavir, navir. Okay, the drugs ends with navir. And dolutegravir, okay, that is integrase inhibitors. So the protease inhibitors mainly causes metabolic side effects like hyperlipidemia and hyperglycemia, and the nucleoside reverse transcriptase, lemivudine, abacavir, all these drugs causes bone marrow suppression. That is why in children with anemia, these drugs are contraindicated. And intinavir is a drug, navir, so it is a protease inhibitor. Intinavir is a drug which causes renal stones, okay, calcium oxalate stones. And abacavir, it causes hypersensitivity reaction like Stevens-Johnson syndrome. Again, abacavir is nucleoside reverse transcriptase inhibitors. And efavirenz, why it has been withdrawn means it causes vivid dreams and hallucinations. Okay, yeah. And as far as so these are the classes of drugs. And as far as vaccination is concerned, all live vaccines are contraindicated only when the CD4 count is less than 200. If the CD4 count is more than 200, MR, MMR, all those vaccines can be given to HIV patients. Only when the CD4 count falls less than 200, we can give these live vaccines are contraindicated. All killed vaccines can be given in HIV patients. Okay, so these are the points you have to remember. What is Haart? Highly active antiretroviral therapy, which is a lifelong therapy made up of tenofovir, lemivudine, and dolutegravir, lifelong, irrespective of the stage, irrespective of the CD4 count, start in pregnancy, start in children, lifelong therapy. This is the dictum of therapy in as per NACO guidelines. Thank you.